Thank you, everyone. Thank you for having me to the Cancer Center. It's really my pleasure to be here as part of this sexual health series. And just to introduce myself, so I'm Joanna Wolfson. I'm one of the psychologists at Rusk Rehabilitation. So it's an outpatient adult psychology department that's part of NYU Rusk. So we see patients that are both referred through the Perlmutter Cancer Center and then also that may be seeing therapists of other specialties like physical therapists, physical medicine rehabilitation, doctors and specialists for other symptoms that have resulted from cancer and treatment. So I'm a health psychologist by training. I see people through the hospital with a very wide range of medical and health conditions. I've been working here for about 10 years, and the Cancer Center is just one of the many places that I work with. And then I've also had the pleasure of running some groups in our department. And so I'm here tonight to present on the topic of sexual health. Tonight, we're going to be talking about the psychological aspects of intimacy. And I know that other speakers in this series have talked about some specific conditions like prostate health and then impacts of treatment on female-bodied and male-bodied individuals. So some of this might be a little similar in terms of some symptoms, but we're really going to focus on how does psychology overlap with some of the treatment implications of cancer and its impact on intimacy that really are very integral in differences that people may have experienced in changes in sexual health, changes in intimacy. I have no disclosures. And the learning objectives of this talk are really after this presentation, people should be able to identify the psychosocial stressors that are associated with changes in intimacy that do happen during and after cancer treatment. The ways in which psychological factors can impact intimacy. We don't always think so much about this, but it can be one of the main reasons that people have a difficult time returning to intimacy. And then interventions and strategies, just sort of like what are the basic tips and tools that might be helpful to even walk away with today for addressing some of these changes. And this can be, changes because people are just dealing with cancer, because they've dealt with treatment fallout, and then even in survivorship when people are still, you know, maybe active cancer treatment is done, but people are still living with cancer and still living with the thought about it and the aftermath. It's still a time where a lot of these changes might feel very prevalent. So I wanted to start by just addressing what even is intimacy. And so intimacy, the definition is really just a closeness, a familiarity, a connection with another person. So this doesn't have to be physical. It can be. It doesn't have to be sexual. It can be. But it can also involve emotional intimacy. So feelings of love, closeness, trust, mutual care and concern. And this also doesn't necessarily have to be with a specific romantic partner. It can really be with anyone that you might feel close with. It could be a trusted friend, it could be a member of the treatment team, but that intimacy can take really many forms, and you don't have to have a partner for intimacy to matter. Um, Physical intimacy is really any form of physical touch. So examples might be just hugging, cuddling, just kind of like a pat on the back or like a touch on the hand for comfort. And then intimacy can be sexual. So it can be the physical act of sex and the emotional closeness that it causes. And people can be, as we said, intimate without having sex, and people can also have sex without it being intimate. So both of those things don't necessarily go together. But often, intimacy is almost always needed for sexual relationships to feel pleasurable. And it relates to sexual health. So when we think about sexual health, that if people have greater intimacy and emotional closeness, then it can lead to greater pleasure in sexual relationships. Feeling, again, closeness, it's really crucial for the openness someone might feel and just being able to even express what are my sexual desires and needs? How do I talk about my worries, my fears, my vulnerabilities? And even things like not being sexual can later positively impact the desire to be sexual. And so, why is this so important? What is it about intimacy that even brings it to the table tonight? Why are we talking about this? And so, there's a lot of research on intimacy and sexual health. There's a lot of studies about it. I'm just going to hit on some, which is not an exhaustive list of all the reasons why it's important. So first, just thinking about, as humans, we're social beings. Having close, intimate relationships, both sexual and non-sexual, are really important parts of our well-being. Physical and emotional closeness is a basic need, and actually, there's a lot of studies, even with animals, where if they don't grow up with like a comforting um, parental or caregiving figure, then they can actually develop a lot of health problems and maybe even, prematurely have problems they wouldn't otherwise have. So, intimacy and sexual health are really integral to quality of life, which is why this whole seminar series was created. So, again, these benefits of intimacy, they're not just about people who are partnered or in romantic relationships, um, but even people who don't necessarily have one partner or a partner at present, just a way to think about how would I even feel comfortable approaching someone or trying to be close to someone. So we know that intimacy, when people have it, it increases a sense of happiness and pleasure. So this is true of even intimate platonic relationships. It can really have a positive impact on people's mental health. It can help to ward off stress and depression. Some of these hormones that course through people's bodies, like cortisol, if people have a higher level of intimacy with people in their life, actually those stress hormones are not as present in people's bodies. There was this one study that I really loved about this is the increased confidence and reduced challenge part, where friends came to a study and they just stood next to each other. They didn't touch, they didn't talk, they just stood next to each other. And they viewed a hill in the distance and they were asked to say, how challenging do you think it would be to climb this hill? And if people were standing next to their friend, they perceived it as less challenging. And if people were standing on the other side of the room from their friend, they thought it would be more challenging. It just kind of shows that closeness to others really makes us feel safe and secure. There's a lot of relaxation benefits, and physical touch in particular. People probably have heard of that hormone oxytocin. So when we hug or we cuddle, again with anyone, it releases this in our bodies, and it's a way to help regulate again the stress response, promote feelings of well-being. And studies have even shown that intimacy makes us less prone to illness. It boosts immunity, helps with things like heart health and life satisfaction. And then, why are they so important to address specifically in people with cancer? And so, there's a lot of research on this, but just to hit on some of the highlights. Um, so, many people, when they deal with changes, and we'll get into kind of what those are in a minute, it really can negatively impact people's sense of identity, self esteem in relationships. And so, simply that people who've dealt with cancer and they experience reduced closeness of any kind can be at increased risk of feeling distress or having a poorer quality of life. So, the previous slide, it's like if that's taken away, then all these things are at risk. Um, when people do have this negative impact of intimacy on, again, identity, self esteem, maybe feeling guilt or shame, and we'll come back to some of these things later, then these actually feed back into intimacy problems. So it's just this sort of circular vicious cycle where it's harder to be sexual or physical or emotionally close in the same way. And then people feel maybe bad about that, upset about that, distressed about that, can lead to withdrawing, and then there's more intimacy problems. And actually, sexual health problems don't just get better by waiting around. So they actually worsen over time if not addressed. And that's simply because they're not being addressed. It's not because things are necessarily rapidly getting worse with a sexual problem, but just that the longer that people go without intervention or the longer that people avoid, the more things can kind of crop up. Um, and then also, difficulties in this area are a primary predictor of non-adherence to treatment. So it's one of the biggest reasons that people might drop out of treatment. And this is especially true in female-bodied individuals with breast cancer, even if treatment is potentially life-saving. So sometimes the long-term difficulties people have with things like sexual arousal and desire are really among these key causes of either early discontinuation or just not even engaging in things like estrogen reducing treatments or ovarian suppression. And additionally, let's say in women who've been found to carry a hereditary cancer mutation gene, and they're told maybe they have a high risk for breast and ovarian cancer, that these concerns about the medications and sexual side effects of treatment might actually be a central reason for delaying or ignoring recommendations for any risk reducing surgeries. So, in terms of the many impacts on intimacy, and there are many, so just here's what we'll go over. And talking about the impact of cancer on intimacy and sexual health. So, the first thing is that most people who have had cancer treatment say that they do experience changes to intimacy and sexuality. These can be temporary or they might be long term. And many people do find this to be one of the hardest aspects of life after cancer. And this is not limited just to things we might think of that involve the pelvic region. It's not just related to ovarian or gynecological or prostate cancers, but it's really common and distressing in a range of all cancers. Um, in terms of the prevalence rate, so there in papers, it's vast. It really widely varies depending on a lot of different things. So depending on like what is the primary diagnosis, what treatment did people have, what's the type of sexual difficulty we're even talking about. But estimates range from 40%, and in some studies, everyone says that they have problems. And some specifics are that for people with breast cancer, over 50% of women treated report some long-term changes in their sexual function, and even rates for young women who've undergone ovarian suppression might be as high as 80 to 90%. So it's very prevalent. Gynecological cancers, people report 65 to 90% of women report this type of sexual dysfunction. And for people that have had colorectal cancer, 60% or more say this. In one sample, 100% reported pain with sex following surgery. So again, you don't have to be partnered for this to be important, but just even being able to have the self-confidence to approach intimate relationships of any kind can be affected. I'm not going to go into too much detail, but I'm showing this because one of the treatment guidelines for people when they have reduced intimacy, reduced sexual health, problems of any kind, is that people really have to understand the education about why is this happening to me? What is happening? And so there are so many things that go into being sexual beings, that go into the sexual response. And if we're going to address it, we have to know like why even do we need to talk about this? So sex starts in the brain, and this is where sexuality of any kind starts. So your interest in being close to people, your interest in even hugging someone or being physical. The brain is the main sexual organ for both females and males. And so if you think about it, like it's really hard to, let's say, like mundanely go from eating a sandwich to immediately feeling aroused. There's usually kind of our feelings, our imagination, our thoughts are really needed that happen at the brain level for us to be able to even feel desire. So the brain is part one. I kind of say sometimes it's like if you think about body image, which is that's held in the brain, um, how you feel about your body and think about your body really matters when you're willing to be intimate with someone. And so I always think about this analogy, which is not a very good one, but if you imagine you're going to a party and you are really rushing out the door and you can't find the favorite outfit that you thought you were going to wear and you imagined wearing, and now you're wearing something that maybe you've had for a while, or there's like a hole in the sleeve, or it's just something that you don't feel your best in. And now think about how you'd feel at that party. People might feel a little distracted, a little self-conscious, maybe like, oh, do other people think that I haven't really, put my best foot forward? And now kind of imagining, well, now if there's a change in the body because of surgery or scarring or other things that have just really impacted ability to be as sexual as before, then you're dealing with this type of thing all the time when it comes to intimacy. So other than the brain, erogenous zones are another important part of the sexual response. That's any area of the body that can make you feel excited or aroused when touched or stimulated. So of course, the genital region, other erogenous zones, the breasts, nipples, chest, mouth, ears, neck. So a lot of these things can be impacted by various forms of cancer and either feels like I don't have the parts I used to have that really help me, or that they've been impacted in some way. And then hormones are very important. So androgens, which are often called the male sex hormone, like testosterone, and then estrogen and progesterone, often called female sex hormones, but usually present to different degrees in people who identify with any gender and sex. They're really needed for things like, keeping and getting an erection and keeping the vagina lubricated. So a lot of these things are impacted by treatment, and I had pluses signs because other things like cardiovascular health also matters. So I'm not going to go into detail because these were shown, I know, in some other talks, but there are so many possible reasons that would impact intimacy and sexuality. So ranging from surgeries where actually there is loss of a body part or a sensation, even the hormonal shifts that might come along with things like having a hysterectomy or having a prostatectomy that really change people's ability to feel engaged and desire. Chemotherapy and radiation and all the other things that we're going to talk about can really impact just feeling well. And so it's really hard when you don't feel well to feel like you also want to be closely touching someone else. Um, People may experience like all the body changes or the pain or the skin changes or, the real barriers from things like endocrine therapy that change the way that the genital region functions. So there's just a vast, it feels like you might not have one treatment, but the next one may be part of the culprit. Um, and then I'm going to switch into the psychology part of this. So I'm going to, in a second, show a different slide about specifically how some of the psychological stressors can impact intimacy. But I just like to first open with, in general, what are the general psychosocial stressors of cancer and its treatment? Um, Many of these don't necessarily tie directly to intimacy, but I'd say all of them impact it in some way. And this is not a full list. This is just a sampling of things that people talk about. So, we talked about side effects and even anticipated side effects. So, sort of waiting around to see, how's this going to feel if I do this for the first time? Or I just actually before this met with a female who's taking tamoxifen and, kind of said like, sort of just every minute of irritability or every time there may feel like there's a change or a hot flash or a pain somewhere, it's hard to know, is this the medication? Is this me? Is this my mood? Is it cancer returning? There are just so many thoughts that can course through people's minds. Um, One thing I want to say about just like chemo side effects in particular is that with most distressing parts of treatment, people list chemo side effects and sexual health changes are often listed as the most distressing parts of the cancer course. And distress can intensify when people expect symptoms to disappear, but instead they persist. So if they don't really talk about this with their doctors, or doctors say, oh yeah, you should be healed in this much time after a surgery, and then people feel like I still don't feel like myself, that can be very upsetting and kind of feel like, can anything help? Will I feel this way forever? Is anyone going to be able to help me with this? Grief is a really big one. And I think when we think about grief, we may think about, loss of a loved one. But grief can really be about the loss of any part of ourselves. So the loss of body function, the loss of pleasure, the loss of desire, like I knew it before, kind of like, is it the loss of intimacy or my sex life as I knew it? This was never so hard before. So the grieving process is something that can happen even if people are doing well. People don't have to be ill to have grief. Um, but just because, let's say, cancer is well treated doesn't mean that people shouldn't experience this. We talked about worry, this worry that maybe I may never be the same. Time is a big factor. When I see people sometimes are, even yesterday, I was supposed to see a gentleman who is going through a cancer diagnosis. And, he had to cancel his appointment because two of his other appointments ran over. And then he had to run to the next one. And so just time of dealing with all of this and time taken away from other things. People's lives still exist even without cancer. So it's not like every other stressor or part of caregiving that people have to do takes a back seat. And so there's less time also to kind of focus on and prioritize intimacy or figure it out. Fear of progression and recurrence is really common. And actually, this is the one that brings people the most to psychotherapy. So I always find this an interesting statistic that fear of the unknowns and especially cancer recurrence, which can happen, every time a scan approaches for many years, it is one of the most prevalent and prominent concerns for which people seek professional help. But I sometimes wonder, is that partly because sexual health is not necessarily brought up or discussed at length? Because I think sexual health would be another one that people might seek treatment for if there were more conversations about it. So adjusting back to life after treatment, people may think, oh, I should be fine now. Cancer's over. I should be just not talking about this anymore. But yet sometimes that's when we see the most people come to psychotherapy is like, this may be behind me in some ways, but now I finally have a chance to breathe and I'm just processing what this has been like. And then feeling isolated from partners and friends, not everyone can understand this really or get inside your body and see what this has been like. So some of that obviously has impacts we talked about to intimacy and sexuality, but here are some of the ways that it really directly impacts intimacy. So, for patients, when there's these body changes, they may feel like it's a threat to my femininity, my masculinity, wherever people lie on that continuum. I think about, people that have maybe they're going through hormone therapy for um, transgendered individuals. And now they're told actually they have to stop that therapy and they have to actually undo or sort of resort to their body being very different from how they imagined it or wanted it to be. For women who may be on some type of hormone replacement therapy for menopause and to be told you actually have to stop that now. There's a lot of things that can really be threats to identity and to people feeling like they can really express themselves, look, or feel like they want to. So when people have reduced self-esteem and self-confidence from all of that, it makes it much harder to feel confident in approaching or talking about or even trying to be intimate with a partner. There's a lot of fear, fear of pain and discomfort and worry that if we start being intimate of any kind, is it going to lead down a path? And then is it better to just avoid anything sexual or intimate altogether? There can be a lot of worry about performance, especially when it comes to things like erectile dysfunction and the real fallout from certain surgeries and treatments. And worry can actually cause, anxiety and fight or flight and more muscle tension and all sorts of things that further get in the way of being able to be sexually or physically intimate. Guilt, shame, and blame are feelings that come up. And sometimes it might even be that there's relief, like people might feel a relief in not having to have sex, that maybe people, um, kind of felt like this was never something that was really comfortable to me in the first place. And now I have a reason not to. And that's okay. That feeling does come up for people. And it's not uncommon that people may have a really wide range of emotions about this. And then people say they're sort of just focused on a burden. I don't want to be a burden to anyone. I'm sort of worried about my partner. Should I do this for my partner? And then separately for partners, I want to acknowledge, there may be partners here on this webinar right now, and that sometimes partners find themselves in a very different role, or maybe they're in a caregiving role all of a sudden, and they're seeing things and dealing with things that they never really expected to deal with, and it might change the feeling of intimacy or like how our sexual relationship feels now. Um, it's really hard for partners maybe to feel unable to help, like I can't quite do anything to fix this problem. And so then they may be feeling inadequate or like they're the ones that aren't able to help with things like desire. Just the other stressors that go on, like stress is sort of a general bubble that can put a wall in between people and relationships. And so other stressors like financial burden, taking time off work to deal with all the medical appointments, now we have to like find childcare, or I also have an ailing mother and now I also have to deal with this. So other stressors again, they just create this further almost like air that it's really difficult to cut through. Maybe guilt about wanting sex when a partner doesn't feel ready or doesn't feel comfortable, and then even worry about their partner's well-being or worry about hurting a partner. In one study, it talked about partners, and that demonstrated that feeling like there's decreased frequency or complete cessation of sex and intimacy was actually reported in 79% of male partners of women affected by cancer. And 14% said they really had to renegotiate just the roles, how to be sexual, how to be intimate after cancer. And these types of changes are most associated with feelings of self-blame, sadness, and anger in anyone going through this. I don't want to go too deep into this, but just to comment on how prevalent anxiety and depression are. So especially when people have greater physical burden of their cancer treatment, or they've been dealing with cancer for longer, it's advanced, they're young, they didn't expect this to happen, chemotherapy. So anxiety is really common. Rates range from about 12 to 25% or more in people with cancer, whereas in the general population, it's more like 3.6%, deal with this on sort of a day-to-day level. And I just want to highlight some of the symptoms include just uncontrolled worry, but physical as well. So it might be things like, GI discomfort, sweating, muscle tension. So these can mimic or play on top of the physical symptoms from treatment. So if people are going through menopause-like symptoms and they sweat more because of anxiety, or people have dealt with a GI cancer, well, now anxiety creates more GI discomfort. And then muscle tension can also make pain worse. Depression is especially common. It's thought that people with cancer are 5 times more likely to experience depression than people in the general population. It's more common in females or if people don't have as much support. And symptoms similarly can really overlap and interfere with being intimate. So symptoms of depression include feeling not motivated, low initiation, so not really being able to take the first step to start a task, not enjoying things as much. So that includes sex, that includes being in close emotional relationships, feeling like, gee, I don't know if this is really going to help me to engage deeply with people or to approach people. And then it's really common that people might withdraw or be more isolated on their own more. And then it's even harder. It's even harder to kind of get back to some of these more pleasurable, intimate experiences. Physical symptoms of fatigue, of low energy, aches and pains. And so these are quite common. It's again hard to determine, like, is this from my treatment side effects or from mood? There's this knowledge that clinical depression and anxiety, they're linked with greater pain and also greater nausea. So people experience greater treatment side effects if they're dealing with these conditions. Okay. I wanted to show a couple of things that I call sort of like intimacy stress loops. So here's an example of the first one. So starting from the top, let's say someone as a result of a surgery has a body change. Could be anything. It could be even a scar that they don't like. And then they might experience reduced desire as a result of hormone shifts from surgery or treatment. So this might lead then to feeling really like a reduced self-confidence or self-esteem, maybe like, oh, I'm not as desirable as I was before. I can't provide as much as I was before. Maybe it's not worth it to engage. And then people start withdrawing and not approaching. And then this leads to interpersonal frustration on the part of the patient, the partner, feeling like this person really doesn't understand what this is like. It's so difficult, and I'm asked to sort of jump through a hoop here in order to get back to something that feels so far out of reach. And then people have reduced contact and they might make more assumptions about their desirability. If one partner avoids, the other starts to maybe withdraw. And then it feels like, yep, confirming my idea that I'm not desirable anymore. And then people focus more on the body change and the whole cycle continues. I'm going to show one more. So starting from the top and talking about pain, so maybe body pain of any kind or pain during intercourse, and then anxiety comes up. So anxiety can come up with any form of intimacy. So maybe feeling like, oh gosh, if we even start cuddling, is this going to lead to something more that I don't want? Having worry about physical discomfort, body tension can be greater, being more vigilant of my body and what it feels like, which can lead to greater pain. And then people have difficulty focusing, low enjoyment. And then here we are again in the cycle of pain, anxiety, more pain. In terms of barriers, meaning, why is sexual health not discussed at great length? Or why is this topic not brought up in all appointments that people go to? A few quotes I really like from different articles. So, unlike natural menopause, young women undergoing ovarian suppression face severe and disruptive side effects. Profound sexual dysfunction is one of the most prevalent and distressing side effects of OS treatment. A survey of patients in a radiation oncology clinic showed that 87% of patients reported that their treatment impacted sexual function or desire, but only 27% reported ever formally being asked about this. And also, most women with breast cancer They do not necessarily take the initiative to seek medical guidance on this, which means that it's really up to the providers, or that there should be a way for providers to incorporate this more into their patients' treatment plans. And so, why does this happen in the first place? There are so many barriers. I could spend like a whole lecture just on this, but I think people might get the sense that, if providers don't bring it up, maybe they don't feel it's important. However, I just want to highlight it's very important. It's your quality of life. There may be many reasons, though, why providers don't, that have to do with them and not at all with you or anything you're doing. So a few things are that, the medical focus is taking priority. Just simply time. The unfortunate fact is that there's a lot of great pressure now with like insurances to see patients in less time. There's a study saying that clinic visit time is now 1/5 of what it was decades ago, which is like an embarrassing statistic. Um, when we think about worry, so some providers say they worry that the topic might cross a boundary. And when they think about ethics, they might feel something like, oh gosh, if I'm a male provider and I have a female patient, if I ask about this, will it be viewed as inappropriate or get misinterpreted? Will I be seen as coming on to one of my patients? It's much safer to ask about neuropathy as a fallout of chemo than to ask about things like vaginal dryness. People often have limited training in sexual health. So I'm not a sex therapist, I'm a health psychologist. This is an interest of mine, but I've really had to seek out training. I made it through, 6 years of graduate school and my internship and various other trainings and my postdoc, and this was never included in my training. So I think that being a psychologist in this, I can only imagine what this might mean for other providers. Um, People may have the sense that, it's cancer is too consuming, that this is not relevant, or maybe if there's no clear solution, it doesn't help to talk about it. But actually, talking about it is part of the thing that does help open up this topic. Some providers may feel it's too personally vulnerable. Some, unfortunately, rates of unpleasant sexual experiences can be high for anyone. Something like 50% of women and 30% of all males at any time have said that, they've had an unwanted sexual experience. So they may feel like this is off limits for me, it's too hard to talk about it, or they worry about making the patient uncomfortable. I don't want to bring up something that feels embarrassing. Um, and then patient factors, there was actually a study with women with any stage breast cancer that asked them what did they perceive to be the barriers to discussing sexual health with providers. And they viewed actually their own lack of comfort or inability to bring it up as a bigger barrier than the expectation that their provider won't react well. So it's interesting because it shows providers have a lot of work to do in making this feel more comfortable. So interventions and strategies. I'm going to focus the rest of the time on this and kind of what do we do. So I just want to first say, in terms of the literature, that sexual health interventions are really important. And the goal of these, it's not to necessarily just take care of the symptoms, but it's to increase understanding, to correct misconceptions, and improve satisfaction. So the reason these work are not necessarily because you're taking away side effects, but you're just reconstructing someone's idea of what their sex life can actually look like and focusing on improving satisfaction. I'm going to go through some of these components in a minute, but the first thing people need is to know. So they have to understand, what are the effects of my cancer treatment on my sexual function? How does my anatomy work? What is the sexual response cycle? What does menopause mean? And kind of understanding about body image. Um, Cognitive behavioral therapy is recommended, so to identify what are my thoughts and how do I alter them if it's appropriate to do so. Mindfulness and other experiential exercises, so increasing body awareness, having pelvic floor relaxation, and communication skills training. And that when people do this, there are really significant positive effects on sexual function, satisfactions, relationships, and distress. For the sake of time, I'm not going to go deep into this guideline, but just letting people know this exists. It's from the American Society of Clinical Oncology. It's really to providers that like they should discuss this and provide education. And if there's a medically treatable condition, let's address it. So if people can benefit from anything like lubricants, moisturizers, pain reducers, other things, medication for erectile dysfunction, let's offer that to people because that can be really helpful and really a game changer sometimes in how people experience intimacy. Um, People should have cognitive behavioral therapy, learn how to just do things like breathe, slow breathing. I'm going to talk a little more about this in a minute. Okay. So, adapting to changes is a really important point of this. And just acknowledging that the changes, there's a tremendous amount of them. So, sometimes the things that we think about as just how do we problem solve through this? And communication, I'll come back to. But one of the first things is just openness and sharing concerns. So if partners don't know what your concerns are, it might be hard for them to be mind readers, and vice versa, right? If patients don't know what the partner's concerns are, they might get the idea that, oh, my partner's avoiding because I'm no longer desirable, when actually a partner may just be worried about their health or fragility. So really, sharing and asking them about their concerns. Um, Thinking about what are the other forms of intimacy that maybe have not been given as much credit in the relationship in the past. So, if maybe sex was a big part of the relationship, just thinking about what else can we do as a starting point? Would it look like cuddling, hand holding? There's been studies about just like sitting on a bed together with various forms of taking off clothing or looking at people's bodies and just like getting back to being together, in sort of a intimate way of any kind. It could even be things like just sharing fears or sharing memories. But I think this important concept of really defining and scheduling what intimacy time looks like. So I think people often have this idea that, intimacy should be natural and it should just happen. And that if we really have a good relationship, like this wouldn't be so hard. But actually, it's really can be something people have to plan for and schedule in. I liked this picture on the right of a couple picking pumpkins. I thought that's so nice, just kind of having a plan for what can we do that feels like we're connecting by doing something maybe that we enjoy that doesn't have to be about sex, but can kind of make us feel like glad to be together. I like this concept of identifying just the next step. So it might feel really overwhelming to think about, oh my gosh, after like a double mastectomy and then chemo and radiation, I have to now get back to this. But thinking about what is just the next step. So is just the next step just scheduling time for a babysitter to come and going out as a couple? Is just the next step just deciding to watch a movie together on the couch? Or is it something like, all right, we're going to lie in bed together and just hold hands, but there's no pressure to do anything else. There's something called sensate focus, which is a part of what sex therapists might do, which is kind of having touch without any expectations. So, trying not to have any preconceived notions about what things should feel like, but just instead noticing what does it feel like. So, you can even focus on things with touch, like what's the temperature, what's the pressure, what's the texture of your body or someone else's body, communicating, letting someone know what I do like, what I don't like, and just having no time pressure. So we have time, there's no end goal. It's just about, noticing without the pressure for it to end in something in particular. Um, and then for sexual intimacy, really planning ahead. So again, not having feel like, oh, it has to be spontaneous, but no, like if we're taking medication to help with an erection, let's schedule sex so we can know that we have time to take the medication and have it work. If fatigue is a really big problem with chemotherapy, thinking about what are my best days and maybe even having other things handy that can help. This is an example of cognitive behavioral therapy, what it might look like. And so, first, want to acknowledge that thoughts come from somewhere, and we wouldn't say that every thought is irrational or needs to be tested, but usually it's common for people's thoughts to kind of maybe take on a life of their own, feel like facts, be more catastrophic, or focusing only on the negative. And when people don't feel well, it's easy for thoughts to take that direction. So, CBT, cognitive behavioral therapy, is really about just noticing and thinking, is there another way to look at this that's not turning a problem into a good thing, but just maybe softening the language? So, examples might be feeling like I'm no longer desirable because of whatever my looks, my body change, my sexual ability. In CBT, it might be reworking that to say something honest. I feel different and I wish I had my old body back. But something like, I can't know for sure what other people are thinking unless I ask. And maybe there are other important things about me that haven't changed. So that doesn't change sexual function, right? It just offers a way to speak in a little bit less of a harsh or overly negative way. Another one, if we start cuddling, it will turn to sex. I don't want that right now, so I better keep a distance. So another way to say it is, I don't feel up for sex. However, physical and emotional closeness may still feel good. I'll feel better if I manage expectations in advance. And then something like all or nothing thinking, my symptoms are awful and they get in the way of everything. And focusing on that sometimes can make symptoms feel worse. So maybe my symptoms make it difficult to be physical in the same ways. I can still be intimate if I take it slow or use lubricants or, use other methods. Keeping my eye on the time, I'm going to go into this because I think it's very important. So having a way to practice some form of relaxation. And some of the things that are shown to be most helpful is just slowing breathing. So, whenever we feel fear, and that could be of anything, but fear of intimacy, of pain, of like discomfort, the first thing we do is we clench our bodies and we hold our breath. And then when we do that, we feel more pain. So, we're not relaxed, we have more stress hormone, we are worried, we're on edge, we're on guard. Having a way to slow down breathing relaxes all muscles, and it just provides a better chance that intimacy of any kind goes well. Progressive muscle relaxation is like tensing and releasing different muscle groups. It could be done with any part of the body. Some people do it with their pelvic floor. Some people do it with, like their arms, their shoulders, their neck. And it's a way to just remind yourself of the difference between being very tight, which does not help, again, with intimacy and sexual functioning or closeness, and how it feels to just be relaxed and kind of more open and ready. I really like this one. I'm going to skip to the grounding exercise, 5, 4, 3, 2, 1. So it's about trying to find in your surroundings 5 things you can see, 4 things you can touch and touching them and noticing it, 3 things you can hear and listening for those sounds, 2 things you can smell. So going like smelling a nice candle or tea, and 1 thing you can taste. And it's a way of just sort of taking your body and bringing it down to earth. So sometimes the act of thinking about being more intimate can like make people kind of spiral into another world, but just I'm here, I'm safe, I'm in this room. Um, Hypnotic techniques, this is something where it's really just about suggestion. So there are studies been done with women who've had menopause as a result of their treatments and who maybe are dealing with hot flashes. And if they have a relaxed stance, and the suggestion should just be imagine their bodies being cool, imagine being relaxed. Actually, they have fewer menopause symptoms after that. I like these apps. The bottom one, Rosie, is something that I was made aware of it recently. And what it is it's an app that their catch line is from low libido to migraine, PCOS, and menopause. Rosie is your trusted companion through thick and thin at all ages. And here's some of the topics that they focused on. So I wasn't aware of it, but it's includes suggestions for people following cancer treatment, and I just wanted to include it as something just simply because it's out there. Okay. And body positivity is really important. So this idea that you know, it really matters for people to feel good about themselves. And sometimes instead of again waiting around to feel good, taking action to do things like just wearing clothes that make you feel good. Sometimes picking out something new, like an adaptive swimsuit or some type of head covering or your favorite perfume or going to a salon, just making a point like I'm going to get up, I'm going to get dressed, I'm going to wear something I feel good in, spending time with people that make you feel good about yourself. Of course, sleep and exercise always help, they never hurt. And then really talking to others who have been through similar changes. There's this organization called lookgoodfeelbetter.org. And it's a way that it's for people with cancer. That's just suggestions and ways of thinking about body positivity. Okay. This is one of the last things I'll share is communication options. So with providers, it can be really vulnerable, to bring this up, especially if a provider isn't. These are some things that people have either decided they want to say or thinking about. So some keep it clinical, right? Since starting my treatment, I've been having pain, dryness, low desire, just keeping it kind of to the symptoms to see if it can open up the conversation. Simply saying, I'm having some concerns about my sexual health, right? And is it okay to talk about this? And maybe focusing on the relationship. My relationship has been impacted by my side effects. This is important to me. I'd like to find ways to make this better. Um, with partners, maybe things like I want to take this slowly. I'm worried about how I'll feel and do. Or is it okay if we just do whatever it is for now? Maybe like, I'm worried about my body after surgery. What do you think about it? Have you had any thoughts about it? Just to kind of clarify what might be going on in your mind about what people are thinking. Um, I can't do this the same way as before. Other options we can try. Or, if it's a new relationship, cancer changed some things about my body, but I'm still interested in a relationship. I wanted to remind people of these Perlmutter Cancer Center resources. So you can always talk to your doctor, your nurse, any provider if you want a referral to people like social workers there, to psychology. So, I'm one of many psychologists that exist here at Rusk Rehabilitation. Um, we have a pretty good, extensive team. And there's also a psychologist at the Cancer Center, Dr. Jennifer Lewis. Some of you may have met her. So there's a few options. So talking to your doctor about it. There's also a psychiatry team there. Um, there are different stress management groups at the Cancer Center. Usually the social workers are great. They know everything about all these resources. This talk and the other talks through the sexual health seminar series are on the YouTube channel. They will be posted. So the Cancer Center's YouTube channel has a lot of archived videos about lots of different topics. This picture on the left is the Center for Midlife Health and Menopause. That's, I think, Lori Jeffers, who gave one of the talks about the female-bodied changes that can occur. And sometimes a referral to pelvic floor rehab. I know that was one of the last talks that was given. Lastly, I just wanted to, let's see, just let people know about, oh, sorry, you can ignore that part in the middle, but there's a bunch of different websites of resources. Some of these are places that might take insurance or just good to know about, like the American Association of Sexuality Educators, Counselors, and Therapists. The first few are ones that are just more group options and might have a way to search for insurance-based providers. The ones on the bottom, I put because I know these people personally. They are all trained, and their websites are here. If you want to take a picture or screenshot, you're welcome to. They're all trained in sex therapy. I like all these people. The first person, Cindy Gelber, she is open to sharing. She herself went through cancer, and she's trained in sex therapy. And so I really, she also has more reasonable fees. So I put her first, just as someone who I trust a lot. And I believe that might be everything. I know I talked a lot. So, and that's my information there, which you're welcome to copy down. And again, you can always talk to your provider if you'd like a referral to psychology of any kind. Okay, so dealing with body image concerns during and after treatment, I just want to acknowledge it's okay to have concerns. It's so hard to feel not in control of your body. And I think the first thing is always talking to your doctor to just let them know about the concerns, like if there's anything that they can help with or they can recommend. Um, but I think sometimes it relates to this feeling that something is really different about you, which is true. Um, and this idea that maybe other people, such as a partner, are, perceiving things that are judgments, like I'm going to judge you for this, or, I'm going to view you as much different. So usually talking about them can help. I'd say talking about it with your doctors, with a therapist, with a partner. And then again, I think that website, like Look Good, Feel Good, can be a nice resource because they have all sorts of people that have gone through it that might have other suggestions for dealing with body image concerns. I appreciate that. And I hope that some of the maybe like comments at the end about the communication tips can be helpful. I think often people are really reluctant to bring it up because they're like, I don't want to offend someone, or I don't want me bringing it up to be sort of calling out that I recognize this is different and I don't like it. I want this to be different. People are treading lightly. Sometimes it's okay to say something like, something's been on my mind and you know, I bring it up just because I want to know what you think about this and I want to bring it up without any pressure. But something like there's a lot of things that are being focused on, right? Your nutrition, your diet, your sleep. Um, No one's asked me over the course of this about things like sexual health. I don't know if people have asked you about it, but I just wanted to know what your thoughts are about it. Um, Sometimes just having kind of like a neutral conversation about it. Hitting on much of what people do say to me, just feeling things that they don't want to feel, like emotionally distant or uninterested or too tired. And, medications are really can make people feel this way. It's often not like people are making this stuff up, it's sort of really the fallout. So I think, again, I think often having any conversation is usually better than no conversation. It doesn't mean it will go exactly how you want it to go. But sometimes rather than bringing it up in a frustrated moment or a very upset moment, kind of saying something like, this is a topic I've been wanting to discuss. I've been reluctant because I don't want it to turn into necessarily having to be intimate, but it is something that has been on my mind. Um, can we schedule a time maybe to talk about it? And so sometimes if both people know this conversation is coming, people can also prepare their thoughts in advance. That's having rules around it, right? Like, I want to be able to talk about it on the couch at this time with no distractions. Like, we're not talking about it when we're also on our phones. We're talking about it not when the kids are still awake if you have children. We're talking about it when like we're together and kind of like we'll talk about it with no pressure to change anything right now, just opening up the conversation. Sexual trauma is a big one. We didn't talk about that, but I want to say that I really appreciate that question. There was this case I'm thinking of someone who had a gynecologic cancer and found the cancer because after having intercourse, noticed bleeding, and then went to her doctor and ultimately was turned into a gynecologic cancer. So now thinking about sex is a complete trigger of trauma, and this is how my cancer was found. I have to get back to this. So I do think that having a therapist in these cases can be really helpful to talk through it. um, I think in general, if people are finding that they're struggling with, and I see the next question too, I'll just kind of pair it, they're struggling with trauma, they're struggling with depression, they're struggling with anxiety, um, and nothing has really helped. I do recommend speaking to someone. A therapist is kind of different from speaking to your partner. It's different from speaking to a family member. It's different from even speaking to a doctor that might be treating this more clinically, but someone who's really trained in understanding um, these changes. So I recommend someone like either a sex therapist if you're looking to really get back to sexual activity and there's a lot of barriers, someone trained in sex therapy. And there are many people out there. The screenshot that or the screen that I showed before of the resources, all those people, I actually met them not long ago through like a therapist meetup type thing. And there's so many people that do this type of work. Um, it doesn't have to be someone who specializes in cancer. I'd say that many sex therapists actually by default deal with people that have gone through cancer because it's so prevalent in that community. So even if people aren't working in a medical hospital, like many sex therapists will say, I do see people with cancer in my practice very frequently. And then, or a therapist who's trained in trauma or sexual trauma for the first question, I think can be very helpful. Awful. I'm sorry that's the case. And I know it's like, this is also just such a misinformed part about insurance panels. So my thought is that I don't like it. In terms of still like seeking out therapy, I think a few options. So one is that, and sometimes people may know or not know this, but that even if a provider who's a sex therapist is out of network, make sure to always check with your insurance company because a lot of insurances might provide out of network benefits that people don't even know about for mental health services. So that would be just part one. So sometimes people say, like, my insurance covers actually much of the cost of an out of network provider. The other thing is that there are some of these resources like Psychology Today. There are a few others that you can search by specialty. So in Psychology Today, I like it because you can put in sexual issues as one issue and then cancer. And you can get providers that specialize in both of these things and that take your insurance. I'm so glad that people attended, and I really, really hope that people can take something practical away from this and just validating, this is such a difficult thing to be dealing with, and it's not often something that's addressed first and foremost in treatment. And these problems they're real. It's not like just because of anxiety they're happening. They're happening for so many reasons. People find themselves in spots that they never thought they would be in at any age, but especially, kind of being young and having kids and not thinking that this could happen to you. So with that, I really want to thank everyone for being here, and you're always welcome to reach out to me with questions. And with that, I will sign off and let everyone sign off and enjoy their evening.